very much. My case is about the transcatheter approach of the multiple valve disease. I will present a case of a 71-year-old female. She was on NIHA class 3 under optical medical treatment with 2 recent hospitalizations for heart failure in the last 6 months. She had COPD, diabetes, and chronic renal disease. No coronary artery disease, elevated NT-proBNP, and pulmonary hypertension, and a Euroscore 2 of 7.6. And that's the MR. It is severe MR of ventricular type, if I may say so, and in the 3D we see there is clearly a coaptation gap between the anterior and the posterior leaflet, here, and there also. And that's the tricuspid valve. There is also a TR, which is massive. You see here the vena contracta and the pisa. And again, it's a secondary severe mitral regurgitation, dilated LV with ejection fraction 45%, and a massive TR. The question is, what should we do? Should we treat isolated the mitral valve? Should we follow a wait-and-see strategy, or should we perform a concomitant therapy of both valves? And there are, for the concomitant therapy, pros and contras. Improved outcomes with concomitant therapy, no risk of undertreatment of the progressive TR, no need for additional general anesthesia and vascular access in frail patients, and no additional hospitalization required. There are the pros. Contrasts are the possible overtreatment of patients with reduced TR post-MTIR, that sometimes there are problems with the imaging of the tricuspid valve, that we need sometimes also separate the delivery system and more money. Unknown is the learning curve, the technical feasibility, and of course, if there is an increased peri-procedural mortality or other MACEs. We decided for combined M-TIR and T-TIR. And we start with the mitral valve. We see our device open here. It's an XDW mitral clip. And then after clocking and performing a 3D also on the ventricular side, then we perform the clipping on the right panel, and we record also the grasping to review. But we see that there is a remaining jet on the lateral side, and we put a second clip here with nice result, as you can see. And after that, we assess the ASD, and you see there is a right to left shunt through the iatrogenic ASD. And we go then, after inserting the clip on the right side now, we go for the tricuspid valve. That's the transgastric view. To clock right the clip, and that's again the transgastric view. We go for the anteroseptal, and that's the mid-esophageal view. And we put one device and reduce the regurgitation. And that's the end result of the tricuspid valve clipping on the left and the mitral valve clipping on the right. And after that, we had an oval-shaped 7 millimeter iatrogenic shunt ASD with remaining shunt, and we decided to close it with a device. And you see, we put the device here, and we close also the ASD. That's also the result. After 1 month, there is a trivial MR, a trivial TR, and no ASD flow between the right and the left atrium. Thank you.
So this was an excellent case. So your plan from the beginning, Ilya, was to
go for both valves.
For both. Mm-hmm. And did you anticipate that you might have a problem regarding the ASD iatrogenic, communication?
After putting the clip in the tricuspid valve, we had right to left shunt, an existing and remaining right to left shunt, and that's why we decided to close it.
So, there was no compromise in the hemodynamics of the patient? So
not really. We had the desaturation in the beginning, but we had also the possibility to extubate the patient, to wait and look if it gets better after the extubation. But we decided to close it.
But this is very rare. So patient, I didn't see, but was on did he have pulmonary hypertension?
Yes.
This patient?
He had pulmonary hypertension. He had also the jet, the remains after putting the clip in the tricuspid valve was directed to the septum. Maybe that played a role too.
Okay, so this is interesting. So, Dr. Mezilis, do you have a similar case? Do you ever close
with the closure of ASD?
Defects?
No,
yes.
we sort of thought of it in a couple of cases, but we're waiting to see whether there's a desaturation, which did not exist after the extubation of the patient. So we didn't go on to close the ASD. But I'm sure that the decision is not based on the size of the ASD rather than the hemodynamics and the saturation.
So if you have a desaturation, maybe you can wait a little bit and then extubate the patient and then take it from there?
That's right.
Dr. Zarogiannis, do you do that? Okay. Dr. Voudris, yes.
A practical question. What's about the DRG, the approval you're taking?
Yes, about the money, I don't know.
Because it's a good idea to...
I'm not sure about that point.
Because as I've seen, we have an approval for mitral or for tricuspid clip.
We worked with a tri-clip guide, and we put and we did both valves with the same approval.
I think that if you use
the company provide.
Yes.
All.
You can do the mitral and the tricuspid in one DRG. The problem is the ASD closure, which requires a second
indeed.
one. Yeah.
That's a big problem. That's a problem.
Fine.
We also have Dr. Triantafyllou and Dr. Spilias as commentators. So, Dr. Triantafyllou, do you have a comment on that and the issue that we were discussing on desaturation of the patient and whether or not to wait for the desaturation, probably to go to resolve by itself when you extubate the patient, or do you just place an SD closure device? Excuse
me, Dr. Iakovou, I think I respect the conversation, but one big thing is if we have to do concomitant both valves, or rather we have to do the mitral first and then wait. That's a big conversation also. Exactly. ASD closure, okay, depends on several factors, also on the feeling of the team and on the clinical status of the patient.
Definitely, this is an important conversation that we had also earlier today, and we have some very nice examples. But this was complete. This completes the whole conversation, I think. So, if there are no other comments, we can proceed. So, thank you, Leah. We can proceed.